Welcome back to Optimal Anesthesia. Today we're diving deep into atelectasis, a common yet critical issue we face in anesthesia. We'll explore what causes it, how we can spot it, and most importantly, what we can do to prevent and manage it effectively. The content we're discussing today is backed by the latest research and includes direct references to key studies, ensuring you have the most accurate and up-to-date information. Imagine your lungs as a series of tiny balloons, each one needing to stay inflated to keep oxygen flowing through the body. Atelectasis occurs when some of these balloons collapse, leading to decreased lung volume and compromised gas exchange. But why does this happen? Let's explore some key mechanisms behind atelectasis. First up, we have airway obstruction. Picture a pipe delivering air to the balloons, but there's a blockage, maybe some mucus, a foreign object, or even a tumor. This blockage prevents air from reaching those tiny balloons, leading to their collapse. According to Lee and Chen in 2005, this is one of the most common causes of atelectasis. Next, let's talk about compression. Imagine someone squeezing the balloons from the outside. This can happen when something like pleural effusion, a buildup of fluid, or pneumothorax, air in the pleural space, exerts pressure on the lung tissue. The result? Those balloons can't fully inflate, leading to compression atelectasis. This was highlighted by Su and colleagues in their 2012 research. Then there's adhesion. Think of the balloons sticking together because of some sticky substance. In the lungs, this happens when inflammatory processes cause the pleura, the thin layers covering the lungs, to adhere to each other. This prevents the lungs from expanding properly, as discussed by Yang and Zhang in 2009. And finally, let's consider surfactant deficiency. Surfactant is like a natural lubricant that keeps the balloons from sticking to each other and collapsing. When there's not enough surfactant, especially in neonates or patients with acute respiratory distress syndrome, ARDS, the alveoli collapse easily. Zhang et al. In 2017 emphasized the importance of surfactant in maintaining alveolar stability. These mechanisms give us a clear understanding of why atelectasis occurs and how it can significantly impact our patients, especially in the perioperative setting. Let's dive into the risk factors for atelectasis. Understanding these can help us be more proactive in preventing it. Let's start by looking at surgical factors. The type and duration of surgery are critical. For instance, upper abdominal surgeries are notorious for increasing the risk of atelectasis because they reduce diaphragmatic movement. Similarly, thoracic surgeries, which directly impact lung expansion, also elevate this risk. These insights are supported by studies like the one published in the American Journal of Critical Care by the American Association of Critical Care Nurses in 1995, which identified postoperative atelectasis and pneumonia as significant risks linked to these types of surgeries. Longer surgeries pose an even greater risk due to prolonged periods of immobility. The longer a patient is under anesthesia and immobile, the greater the chance of lung collapse. Now, let's consider anesthesia-related factors. General anesthesia plays a significant role in the development of atelectasis. The use of muscle relaxants, for example, reduces respiratory muscle tone, leading to decreased lung expansion. Mechanical ventilation, particularly with low tidal volumes, can also contribute to this issue. Moreover, inhalational anesthetics may impair normal gas exchange, promoting alveolar collapse. These factors are detailed in an article published in Anesthesiology in 2022, which delves into the biology and mechanisms of perioperative pulmonary atelectasis. Patient positioning is another important consideration. The supine position, often used during surgeries, can reduce diaphragmatic movement, particularly in obese patients, further increasing the risk. Patient-related factors also play a significant role. Individuals with pre-existing respiratory conditions, such as chronic obstructive pulmonary disease, COPD, or asthma, are at higher risk. COPD increases the risk due to chronic airway obstruction and excessive mucus production, as highlighted in a study published in BMC Anesthesiology in 2023. Obesity is another significant factor, as it restricts diaphragmatic movement and reduces lung volumes. Age also plays a role. Elderly patients are more susceptible due to decreased lung elasticity and muscle strength. Additionally, smoking damages the airways and alveoli, leading to chronic inflammation and mucus production, as discussed in a 1995 publication by the American Association of Critical Care Nurses. Postoperative factors can further exacerbate the risk of atelectasis. Prolonged bed rest and immobility reduce lung expansion and promote mucus accumulation. Inadequate pain management can prevent patients from taking deep breaths or coughing effectively, which are essential for maintaining lung expansion. The British Journal of Anesthesia in 2017 emphasized the importance of postoperative pulmonary care, noting that inadequate respiratory therapy, such as the failure to use intensive spirometry or deep breathing exercises, significantly increases the risk of atelectasis. Mucus plugging is another concern, where increased mucus production or impaired clearance can obstruct the airways. This is particularly problematic in patients who are unable to clear their airways effectively. But what can we do to stop it before it starts? Today, we're going to break down the preventive strategies into 3 key phases: preoperative, intraoperative, and postoperative. Let's get started. The best defense is a good offense, right? That's why preoperative optimization is so crucial. Before we even get to the OR, there are steps we can take to minimize the risk of atelectasis. First, we need to address modifiable risk factors. For example, smoking cessation can dramatically reduce the chances of lung complications. As the American Journal of Critical Care, 1995, highlights, encouraging patients to quit smoking well before surgery can significantly lower their risk. Pulmonary rehabilitation is another powerful tool. We're talking about exercises that strengthen the respiratory muscles and improve lung function. And of course, managing chronic conditions like COPD or asthma is critical. These conditions can predispose patients to atelectasis, so getting them under control before surgery can make all the difference. Now, let's move into the operating theater. This is where our skills really come into play. Ventilation strategies are key. The use of positive end expiratory pressure, or PEEP, helps keep those alveoli open. Su et al., 2012, is quoting that maintaining appropriate PEEP during surgery can prevent alveolar collapse. Next, let's talk about anesthesia. Keeping the duration of general anesthesia as short as possible and avoiding the overuse of muscle relaxants can make a big impact. Yang and Zhang, 2009, is quoting that careful management of anesthesia can help maintain adequate lung expansion during surgery. Positioning is also critical. When we position our patients upright or semi-recumbent, we're optimizing lung expansion. Zhang et al., 2017, is quoting that proper positioning can significantly reduce the risk of atelectasis. Finally, intraoperative lung recruitment. Liu et al., 2023, is quoting that performing maneuvers to open collapsed alveoli periodically during surgery can help maintain optimal lung function throughout the procedure. We're not done once the surgery is over. The postoperative period is just as important when it comes to preventing atelectasis. Early mobilization is key. Getting patients up and moving as soon as possible helps keep the lungs fully expanded. This, combined with effective pain management, ensures that patients can breathe deeply and cough effectively, which is essential for keeping their lungs clear. Incentive spirometry and deep breathing exercises are also crucial. British Journal of Anesthesia, 2017, is quoting that these simple interventions can make a huge difference in preventing postoperative atelectasis. Lastly, continuous positive airway pressure, CPAP, may be beneficial for high-risk patients. This can help keep the airways open and prevent the collapse of lung tissue during the critical postoperative period. Let's discuss the best ways to manage it effectively. First, let's talk about oxygen therapy. According to Smith et al., 2023, using supplemental oxygen is a key method for addressing low blood oxygen levels. It's often our first step in managing atelectasis, helping to boost oxygen levels in the bloodstream. Next on our list is chest physiotherapy. Lee et al., 2021, highlights that techniques like percussion and postural drainage can be very effective. These methods help improve lung aeration by literally shaking and repositioning the lungs to promote better airflow. Incentive spirometry is another crucial tool. Wang et al., 2016, explains that using an incentive spirometer encourages patients to take deep breaths. This practice helps keep the lungs open and functioning properly, kind of like giving the lungs a gentle exercise. For more severe cases, bronchoscopy might be necessary. As noted by Zhang et al., 2022, this procedure is useful for removing blockages like mucus plugs that might be obstructing the airways. It's like sending a tiny cleaning crew into the lungs to clear out any obstructions. Lastly, in the most critical situations, surgical interventions might be required. Jackson et al., 2018, points out that procedures such as pleural drainage can be essential when other methods don't work. It's a more invasive approach, but sometimes it's the best way to restore lung function. For those of you interested in exploring this topic further, you can find detailed information and the latest evidence on protective ventilation at optimalanesthesia.com.